Hey, gurus. This is Denise Richland, and we are joining you from beautiful Wisconsin this week. Thanks for joining tonight's Facebook Live. And Bill is with us. I'll let him say hello.
Hey everybody, welcome to the Facebook Live event tonight, our first Q&A. We asked for the Woundiverse to submit your questions to us, and we got those questions, and we are here to take about a dozen of them. We took out some of the best ones, and obviously we didn't have time to get to all of them, but we are going to take some of the top dozen or so questions here tonight and go through them systematically and giving you guys some answers to some of the questions that you guys have submitted. So we're excited to be able to give that information and hopefully provide you with some answers. So with that, I'm going to turn it over. I believe it's our very first question. What do we got?
All right. So this question says, I have a clinician who likes to order betadine soaked gauze on a lot of wounds, including pressure injuries with slough. What are your thoughts?
Well, what are my thoughts? Well, some of you who know my thoughts on a lot of these antiquated and outdated practices of the past probably already can put the words in my mouth. But for those of you unfamiliar, number one, betadine obviously is a antimicrobial agent. It has proven to be antimicrobial. Its active agent, of course, is povidone iodine at a concentration of 10%. Now, why would we make a routine habit of packing a wound with betadine? Well, that really is the question. Being that one, unless there was a bacterial problem, the first question would be is, why do I need an antimicrobial? So unless there's a bioburden issue, there really isn't the need technically for any type of an antimicrobial product in the first place, just in general. Because remember, we always want to start our treatments with what is your rationale? So again, have we established a rationale that we need an antimicrobial? That would be the first one. Second part of this, of course, would be the fact that betadine is not, that would be NOT, not FDA approved for use in wounds. There is zero approval for it. If you read the label, if you look at the FDA approval and clearance on this product, it is only approved for use on skin and first aid antisepsis. That would include minor cuts, scrapes, and abrasions, not full thickness pressure injuries, venous wounds, diabetic wounds. Okay, it's not approved. It is highly cytotoxic. Again, I won't take away from its ability to kill bugs, but again, it's not approved, and we have approved products that will kill bugs in wounds, and that's what we should be using. Plus, on another side note, the pressure injury with slough, there is no debriding capabilities in betadine. So again, we're not doing anything to debride that slough, which should be a priority as well. All right, our next question, I hope that handled that one. How can I tell if my patient has lymphedema? And as a follow-up, there was a second part to that. Does using diuretics help lymphedema?
Well, I think, this is kind of in my wheelhouse being a lymphedema therapist. And we get this a lot. Like, how can I tell whether this is regular edema, lymphedema? How do I treat it? Those kind of concerns. So the first thing to realize that if your patient has edema that's not being, that doesn't resolve overnight with elevation of the foot, you have lymphedema. So then it becomes how do we manage it? Okay. A lot of clinicians are looking to stemmer sign as a confirmed diagnosis for lymphedema, but it actually starts before that. So if your patient lays down during the night and sleeps and wakes up and still has edema, then we've got a lymphedema component here, most probably. And then the second part of that question, I know, is about diuretics. So if you don't have CHF, then we would lean toward lymphedema. But if you have a CHF patient, then edema may be, due to the cardio diagnosis. So when that edema we think is lymphedema, we don't want to be on diuretics, because what that does is it actually draws the water off, and that lymphedema can become kind of jelly-like. And as we do lymphedema treatments, we want to be doing manual lymph drainage, which is where we direct the lymph fluid to different places, and we want to be able to reroute that. So if our patient is on a diuretic, that just means that lymphedema becomes like jelly and it's much harder to move. And as we compress it, it's not able to be treated as well with the manual lymph drainage and with the compression. So I hope that answered that question.
Excellent. I think it did.
All right. So the next question, how do you measure wounds that are open but have no depth?
Okay. Well, first of all, let's clarify that. If there is technically no depth, you don't have a wound, because no depth means that there would be no loss of tissue.
We get that question a lot.
Yeah, this is a very often debated or discussed thing in wound care forums out there on Facebook and other areas. And I've answered this question many times and it just keep coming up. And so we thought, you know what, if they keep asking it, it's time to address it. We still don't clearly understand. So first thing we have to remember, for there to be a wound, there has to be missing tissue, even if it's as simple as the epidermis, which, as we know, has a thickness of about 0.1 millimeters. Okay, yeah, there we go. Sheet of paper. Thank you. Very good prop there. But anyways, so is there depth there? Yes. Now, the question is, can you measure it? And of course, the answer is no, because you probably don't have a micrometer in order to measure that. You have a paper ruler with the smallest measurement being 1/10 of a centimeter. So what we have to do then is we estimate the depth at less than 0.1. Now, when people use the term UTD, or unable to determine, okay, that's another common time they'll say, well, I can't measure it. There's necrotic tissue, so I can't determine the depth. What you need to understand, what was that?
I said I see that a lot,
Yeah.
UTD.
What we need to understand is that you need to differentiate two things. And what I've often taught is there is what I call the actual depth, which is what the wound presents with. And then there is the true depth, which is what the wound depth would be when it is clean. Okay? So you have to distinguish between actual presenting depth and the actual true depth. And so, can you measure the true depth when there's necrotic tissue? No, of course not. There's dead tissue in the way. But measuring wounds for documentation does not require measuring only the true depth. You measure the actual depth, what it's currently presenting with. And if you have necrotic tissue in your wound bed, as you all know, necrotic tissue is representative of dead subcutaneous tissue, which means the only way you can see the subcutaneous tissue, even in a stable heel ulcer, for example, it may not look like there's any depth, but the fact that you can see that eschar means that you're looking at dead subcutaneous tissue. Well, the only way you can see the subcutaneous tissue is that there has to be the epidermis and dermis have to be gone. Otherwise, you wouldn't be able to see subcu tissue. So you have depth there because you have two layers of tissue that are missing. Now, again, you may not be able to physically measure it, but you know anatomically you have missing tissue. So you should at least put an estimated depth of 0.1 or less than 0.1 as a depth measurement, even on a stable eschar. Now, again, with necrosis, if it debrides or you debride it, and I'm not saying you should debride a stable heel ulcer, but any other necrotic tissue, as you debride it, yes, your depth measurement is going to increase. That's okay. That is actually an increased measurement. That is a sign, a good sign, because it shows you, or that shows the reader, you're removing the necrotic tissue, trying to get down to the true depth of the wound. And it's only once you get to the true depth where you have a clean wound bed that you can actually start healing it.
I think a lot of people get concerned because as we debride, those measurements get worse or they get deeper, and clinicians get concerned that this is worse. It makes it look like our wound is worse.
Correct.
So I always coach them to, yes, we're going to increase in depth. We can also write that is anticipated as we remove necrotic tissue. And then you can also be changing the status of that wound. Maybe we're going from 100% necrotic to now we're 75% necrotic and 25% granular. So in fact, we're changing the tissue types, and that's showing improvement even though the depth is increasing.
That is an excellent point. And another point I will add, since you brought that up, is that when clinicians are doing debridement, especially if a clinician is doing surgical debridement, they actually have to do pre and post measurements on the wound after a debridement. And guess what? Those measurements had better increase. Otherwise, the big question is going to be, what did you debride if there's
Right,
no change
exactly.
in size? So
Mm-hmm.
excellent.
Mm-hmm.
All right, let's bring on our next question here. What is the best way to treat burns at home?
So we get this question a lot as well. And I think the first thing to talk about is what burns shouldn't be treated at home at all, right? So looking at if you have a body surface area of greater than 15% in regular, normal adults, or greater than 10% in an elderly or a child, that should be treated at a burn unit or a trauma unit. That's more than what we want to because burns can dehydrate because their risk of infection is so high. Some of the burns are not going to be appropriate to treat at home, right? Also, thinking about burns that have inhalation or chemicals, burns that encompass like the hands, the feet, joints. Um, Even circumferential burns, those can scar down and can decrease the blood supply. So all of that is handled better at a burn unit or a trauma center. But if you just have a superficial burn at home, I know we have great success with a hydrogel or even an antimicrobial hydrogel if you feel like that burn is susceptible to any kind of infection. And then just wrap it with some clean bandages, sterile gauze, in anything basically, because you're going to be changing that. If there's blistering, you want to protect that. And you might be changing that a little more frequently. You want to protect the blisters for as long as you can, but many times those will go ahead and break open. And at that point, we would debride it off and then continue with your maybe antimicrobial hydrogel and just wrapping it up with dry sterile dressings.
Awesome. All right, next question.
All right. I have an order for negative pressure wound therapy on a wound with 75% slough. Is this appropriate?
All right, this is something that I think, and at least in my experience, having been teaching wound care all across the country from east to west coast for the last 17 years. Um, in recent years, or more recent years, I should say, I have seen and at least heard reported from my students that there is this increasing use of negative pressure on more and more necrotic wounds. All right. And again, we're back to what I said with the very first question. First question we always ask, what is our rationale? Okay. So that's what we should be asking ourselves. Now, we know that negative pressure is a wound healing modality. And it does that by removing exudate, decompressing the tissue, mechanical stress on the tissue. But there is nothing about negative pressure that physically debrides the wound. Okay, it doesn't matter what type of negative pressure system you're using. None of them have a physical debridement component to them. They generally are going to maintain a moist wound bed because that's what they're designed to do. And there's even some negative pressures that instill a fluid which soaks in there. But again, all they're doing is making the wound bed more wet. And that's going to increase autolytic debridement. I mean, unless they were actually instilling a chemical like sodium hypochlorite, which can chemically debride, then they would be putting a debriding agent into the wound. But just doing saline or a standard wound cleanser, there's no debriding capability from that cleanser just sitting there stagnantly sitting on top of the tissue. Okay? So that there's nothing debridement. You might be promoting autolysis, but the modality itself doesn't debride. So when you are looking at wounds that have that level of necrotic tissue, we go back to the rationale. What's the rationale for? If your wound right now is the primary focus should be debridement, not using a healing agent. So you should look at a more aggressive form of debridement, maybe some sharp debridement, whether surgical or conservative sharp, maggot debridement, something along that lines to reduce that level of necrotic tissue down to like under 20%. And then at that point, you can probably start introducing the negative pressure because the autolysis will clean up that last 15, 10%, whatever it is, but you're getting a lot more of a benefit from the negative pressure on healing the other 85% of the wound that is clean, ready to heal. All right, I think that handles that question. So, next one on the list. What is the, oh, I'm sorry, pardon me, I'm getting ahead of myself. Can't read my order here. How do I know when to change a treatment?
Oh, yeah. I think we get that a lot. This wound has stalled out, and how do I know when to change the treatment or what to do? So, what we should be thinking about is wound assessments, comprehensive assessments weekly. And then, if we have a wound that has stalled out for about 2 weeks, then let's assess all of the basics of wound care. Have we removed the cause? Do we think that there's a potential infection? Commonly, what is overlooked is what's the nutrition level? Is the nutrition good? Are we meeting all the 6 basics of wound care? And if we haven't, or if we have and we still see no improvement in 2 weeks, then that might be the time to consider a different type of treatment.
Excellent.
So, all right. How do I know if my patient's wound is infected?
Okay, here's a great question. Interesting. We actually did a Facebook Live a few weeks ago with a company that provides what they call PCR testing, polymerase chain reaction. It's kind of the hottest thing out there in the antimicrobial world. Now, again, as you all know or should know, is that the gold standard for confirming wound infection up to this point has been considered to be the punch biopsy, a tissue culture. Okay, where we're removing tissue. That is currently still considered to be the gold standard. However, I do believe, based on the science and the technology behind this PCR testing, is that it also may become the new gold standard in the future. I'm not going to get into it. I would highly encourage you to go back and pull up that video either on our Facebook page, or you can go to our YouTube channel, Wound Care Gurus, as well, and you can watch that video if you want a better understanding of what PCR testing is. But again, in order to confirm that infection, we need to use a test that can actually give us a quantitative analysis of the bacterial levels in the wound. And unfortunately, a standard swab culture can never quantitatively measure the level of bacteria in a wound. All right. And that, unfortunately, then how do you diagnose with that? It can tell you what bacteria are there, but from that swab, you certainly cannot tell which bacteria is causing the problem. Is it one? Is it multiple? You don't know. You're just kind of saying, well, okay, I got all these bacteria in here. And then when it comes to your treatment, how do you decide what to treat? How do you decide which bacteria strain to treat? Because we know that there is no broad spectrum antibiotic, that kills every bacteria. Okay, we've got different strains of bacteria that are only affected by certain types of antibiotics. So now you're like, okay, I got this strain and this strain. I need this one. This one will respond to, Zithromax, and this one will respond, whatever. So I'm like, well, which one do I pick? So then treatment for infected wounds without an appropriate diagnosis, you end up basically doing what I call shotgun medicine. You just kind of blast it with something, and if it doesn't work, then you reload the gun with something else and hit it with something else until you finally hit the magic bullet, so to speak. And that is no way to approach wound care, especially with wound infections, especially when we have definitive tests that we can use, either punch biopsies or the PCR testing. So I would encourage you to look into those.
Also, take a look at your clinical signs. If you only have 2 or more signs, we wouldn't clinically think that it's probably infected at that point. But if you start seeing 3 or more signs locally, then we're starting to think about microorganisms growing within the wound. We might want to treat that topically with some sort of antimicrobial. And then if you have 3 or more signs or symptoms that are systemic, things like elevated white blood cell counts, red streaking, increased pain, larger wounds, things like that, then we start to think about systemic infections. So don't underestimate the power of your clinical judgment and of looking at those clinical signs.
Right. Good. Excellent. That's a very good point. I mean, when you see those signs and you've got them, then you would want to consider your more definitive test to confirm your diagnosis and then your antibiotic treatment if that's how you're going to approach it. So,
Exactly.
All right.
Right.
Next question. What's the best way to treat epibole?
Ah, epibole, that stubborn wound edge that's rolled over, right? And it won't heal. The important thing I think to note is that you have to treat the epibole, right? This wound is not going to close on its own, right? When we have that rolled edge and epithelium has touched epithelium, the body has stalled out. The cells are going to get senescence. The signal to the brain is, yeah, I'm done. I don't really feel like doing anything now because I think I'm closed. So that epibole has to be addressed, right? So the first thing and the most effective then would to have a prescribing authority, someone with a scope of practice that can come in and surgically debride off that epibole. Okay. If you don't have that, then the next best thing, and if it's within your scope of practice, would be to treat it with silver nitrate. And then you allow that tissue to die because it's burnt off, it's cauterized. And then you would come back and you would conservatively sharp debride it.
Excellent. Perfect. That sounds like it gets the job done.
Right. Okay. Next question. What type of topicals can we use to decrease the pain before sharp debridement?
Okay, good question. Again, obviously, most of you probably know, watching in, Denise and I teach sharp debridement. We have our advanced wound debridement course. And sorry for the unadulterated plug, but go to sharpdebridement.com and you can check out our schedule for the fall. We have passed the COVID season, at least for the spring, which we kind of had to shut down classes, but we're going to try to do some classes in the fall. So check out our schedule. If you're looking for some debridement training, we'll obviously be covering this in that class as well, too. But there are a number of ways topically to do that. And I'm going to be honest with you. I've been teaching the debridement course now for about 17 years. And I have had numerous clinicians, prescribing clinicians that come through the training. And the general rule of thumb that I have found in talking to them is that most of them actually feel topicals are a better option than injectable.
Mm,
Some that do both, but I've had some that have done both, and they're like, I like the topical seems to work better. But again, it's everybody's got their own different strokes for different folks, as long as it works and gets the job done. Okay. Um, so getting back to the topical agents. So basically, number one, lidocaine and lidocaine based type products are all an appropriate option to use as long as they are approved for use on wound tissue and or mucosal tissue. Now you have
mm.
to be very careful because there are some lidocaine products out there, and I will mention them by name. EMLA is one because it's been used for years. There's another one called LMX4. The challenge with those products, if you read the actual label, they're only approved for use on intact skin. None of you should be sharp debriding intact skin. All right? So that means it's not approved to put on an open wound bed. All right, there are products that are approved. I know there's two hydrogel products out there. MPM Regenicare has one, and there's also Astrogel. It has the MPM, I believe, is a 2%, and the Astro is a 4% lidocaine impregnated into the hydrogel. And then, of course, any other topical lidocaine product that is safe for use on mucosal tissue. And why mucosal tissue? Because mucosal tissue doesn't have an epidermis and a dermis on it. It's like an open wound. There's no skin over the top of mucosal tissue. And so therefore, you could safely use those to manage your pain. Now, before we go any further, Denise, a
I'm
question
seeing these
just popped
comments.
up. You saw it, did you?
Right, absolutely.
And it
Yes. So
says,
Karen, thanks. Yes, thanks for your comment and your question. When talking about epibole, the question is, can you rub it with gauze if it's not too rolled? And that is a great and very effective way to try to prevent the epibole. If you can scuff it up with those microfilaments with gauze, anything to keep that edge roughed up so that it doesn't heal all the way through, that is a great point. You can hopefully try to keep the epibole from forming. Unfortunately, if the epibole has already formed and it's already rolled and healed down, then the only way is to do some sort of debridement. Mm-hmm.
all right,
Thanks for
excellent.
those comments. We appreciate it.
Yeah. Next question here is, how do I tell if a pressure injury is unstageable, a 3 or a 4?
All right. Okay. Well, I know that unstageable can get confusing for people, right? So we want to think about the layers of the wound and what we're visualizing. So we know that pressure injuries are the only type of wounds that we stage. And unstageable just means that we can't visualize either the wound base or a deeper structure. So if you have a wound that's 100% necrotic tissue and it's higher up, you cannot visualize any of the structures underneath because it's covered with necrotic tissue, then that's an unstageable. But at the point that that necrotic tissue, either by debridement or autolytic debridement, is starting to come out, if you see a deeper structure, if you see bone, tendon, ligament, muscle, any of those, it is automatically a 4. Call it a 4. Okay. You can, in some facilities, you can receive tags by delaying that stage 4 nomenclature. All right. And so don't hide behind the unstageable. Now, I would say as a stage 3, we know an unstageable is at least a 3. Necrotic tissue means we're in the subcutaneous tissue. Okay, so then at that point, we just need to remove enough of the necrotic tissue to be able to visualize the wound bed to either determine that it's not a stage 4 and that we only see subcutaneous tissue, or if we get a deeper structure, and then we're going to call it a 4.
Excellent.
Any thoughts on that, Bill?
No, I think you said it like no better, and you said it, I couldn't say it any better. Let's put it that way.
All right.
Home run, baby. So.
All right. So, okay, another question about pressure injuries. How do I stage a pressure injury if it heals and reopens?
Okay, when it comes to staging a reopened wound, obviously, you've probably heard the old saying, once a 4, always a 4. Okay?
Right.
And again, remember anatomically, when a pressure injury that is a 3 or deeper, when it heals, it does not replace the missing tissue layers. Muscle doesn't replace, fat layer doesn't replace, the dermal layer doesn't replace itself. The only tissue layer that can regenerate is the epidermis. Okay? So if you don't have all those layers in there, there's no way you can go from a 4 back to a 3, back to a 2, back to a 1, because you don't have the layers that constitute a 2 or constitute a 3. Okay? So, nice visual there. So when you have a 4, it's always going to be a 4. If it heals and closes and it reopens, even if it just breaks through that new layer of epidermis, it's still a 4. Because scar tissue is not considered a tissue layer. So it might as well have opened up all the way back down to that bone. Now, it's a little trickier with a 3. So when you have a 3, and that's as deep as it ever got, as it's healing, it's a healing or resolving stage 3. And then when it closes, it's a closed or resolved stage 3. Now, if it reopens, as long as it doesn't present with muscle, bone, tendon, or any of the structures that would determine it as a 4, then that would still go back to being a 3. Once a 3 until it goes beyond a 3 and still can become a 4. But that means it would have to have been deeper than the initial wound, and you would have to have those identifying structures that Denise talked about in the previous question of bone, muscle, tendon, ligament, joint capsule, all that stuff.
Right. Great. Great answer. Great answer. Okay, we have a follow-up to that one too. And it says, how can I determine if the wound on my patient is a diabetic foot ulcer or a pressure injury?
Ooh, now here's another one I get. And this creates quite a debate. I'm actually going to be writing a blog here in either July or August for WCEI on just this topic. So I'm going to give you the abbreviated answer tonight because I'm not going to go on and try to read the entire blog that I'm writing. Okay? The main thing is when you are quote unquote diagnosing a wound, determining its etiology. Etiology is the cause of the wound, not what's contributing to it, although there can be many contributing factors. What we have to do is determine if it is truly caused by one thing in particular. Now, can you have multiple etiologies in wounds? Yeah, we call it a mixed etiology wound. And then it's kind of a crapshoot. You can pick any one of them because they're all, what's the word? They're all significant enough that any one of them could have what created this wound. And so you just kind of give it your best because you're not going to call it a pressure diabetic venous injury. There isn't a classification like that, okay?
Are you sure there's not an ICD-10 code for that?
Yeah. What would that be? That'd be a PVD wound, but that'd be peripheral vascular disease. I would just throw everybody off with that acronym. So one thing I would look at first of all is where is it located? All right. Now here's a clear defined one. If it's on the posterior aspect of the heel, you know, where you get those from laying on your back and not floating the heels, I don't care how bad their diabetes is. Nobody gets neuropathy on the above the back, the bottom of the foot on the back of the heel. That is a pretty rare thing to have neuropathy all the way up that high. That wound is there because of pressure. Now, will their diabetes have an impact on healing? Absolutely. But their neuropathy had likely had nothing to do with causing that wound. Now, when that wound is further down the foot where there is the neuropathy, then we have to look at how much of a contribution did that play in creating this wound. And it could have been pressure from a shoe, but it might have been repetitive friction, shearing, and a rubbing pressure. Okay. So again, that's where you can get in that situation. Well, you know, you could go pressure or you could just go a DFU, which pressure can cause a DFU. Okay. The other thing to understand the difference in pressure is with pressure injuries, remember that is a continuous, uninterrupted, sustained, low or high force pressure that stays long enough in one place to lead to ischemia. The pressure with a DFU is generally repetitive. Very good. Thank you, Denise. I appreciate all the wonderful. What are we playing? Charades tonight. So, but anyway, so yeah,
I'm a learner.
right. It's repetitive because again, and the difference between that is usually with the DFU, the force of those pressures is usually moderate to high. A low force bumping on the tissue is not going to create an injury. You got to have some pretty high forces hitting that area repetitively for it to damage the tissue. However, just a low force pressure continuously on tissue for 6, 8, 10 hours can lead to ischemia because it only requires what? 32 millimeters of mercury of pressure, and that reaches capillary closing pressure. And if it stays there long enough, you're going to end up with ischemia and a pressure injury. Any other thoughts on that, Denise?
Well, I think too, when we think about DFUs, we usually think about the plantar aspect or around the toes, things that rub. Um, Also, look at where those calluses are, because the callus in a true neuropathic wound, you're going to have a callus before you're going to have a wound, most probably. Those are usually the determining factors of, oh yeah, this is going to break open, because we have a callus that then acts like a marble, and since we have that insensate foot due to the neuropathy, then we don't feel what we're stepping on. So that happens quite frequently.
All right, excellent.
I know we have a question from the field, and I'll give this one to you, Bill. It says, would you say that Rojo cushions are the best for preventing injuries?
I wouldn't necessarily say that Rojos are the best. They are a good option. But to say that one product is best, that would mean like saying, well, one size fits all.
Right, I would agree.
We don't want to ever take that approach. Is the Rojo cushion a good option? Yes, it is. But it's obviously not going to be the best option for everybody. All right. And again, we want to use any type of, whether it's a Rojo or a gel-based cushion or any of those good pressure redistribution cushions whenever we're dealing with patients that are at risk and up in a chair. Okay. But it's also very important especially with the Rojos, is to make sure that they're inflated properly. Okay. Underinflated and overinflated, you are just asking for a pressure injury a lot sooner than later. So we have to make sure that's the one thing with the Rojos is the fact of the air inflation. So somebody's got to be trained properly to know what the ideal inflation level is, because I've sat on them when they're overinflated. It's like sitting on a rock. Okay. And when you're underinflated, where you actually sink too far down into it, you're sitting right on the seat anyways, and you don't get that offloading.
Hmm. I would also say too that I think many times I see facilities and I see clinicians trying to come up with the perfect cushion when actually it's just the person doesn't need to be in the chair all day. You know, there's no perfect cushion that's going to work for a patient to sit in the wheelchair all day long. And so I think that's one of those things that we think, okay, if we put the beauty of this cushion on and they should be okay, when in fact we know that these need to be offloaded more often than they are.
Exactly. And Carolyn made a great point. Says you have to rely on the staff a lot of times to ensure the rojo is inflated, and that is true. Somebody needs to be regularly and routinely inspecting that to make sure that we haven't lost, because they will over time they will lose their air. Okay, that just happens. All right, and so they may have to be routinely, slightly, or partially reinflated again to get them back to that ideal level.
Right. Yeah. The other thing I would say too is look at the positioning of the person in the wheelchair, because many times we can adjust the wheelchair as well. You know, we see a lot of our elderly who will sacral sit in their wheelchairs because they just don't have the trunk strength to sit up appropriately. And so what happens is they lay in the bed in supine on their back and they have pressure on their coccyx, and then they sit in their wheelchair in this sacral sitting where they're flexing and they're kind of scrunching down. You're going to see me scrunch down. Yep, just like that. And they're sitting on the same spot. They're sitting on their coccyx and they're never really offloading it because of the way they're sitting. So I would, reach out to one of your therapists, your seating specialists, things like that, because that patient needs to have some posture control done. It needs specific seating interventions in order to be able to offload that better.
Excellent point. Excellent point. Well, don't have any more questions, Denise. Do you have any left on your list there?
I do not. I do not. Folks, you have anything you want to zip in real quick?
If anybody's got anything, throw us at us real quick here. We're looking forward. It is July 1st. We're starting a new month. We do have a number of potential Facebook Lives coming up. We have one on burns that'll be coming up later this month, and working on a couple of very unique products that are coming out in the industry, and we're going to bring those to you as well as potentially some other topics. So we're just going to kind of see how the month goes. We certainly appreciate everybody tuning in tonight with us, and I just want to say thanks, everybody. Have a great 4th of July. Get out and obviously celebrate safely, and
Safely,
follow
right.
your restrictions, but go out there and celebrate the free country that we live in today.
All right. Many thanks to all of you. And hey, we are listening to you all. So if you have topics that you want us to cover, please send us the message. We would love to do the research and bring you those answers that you are seeking.
Very good.
So, everybody have a great holiday weekend.
Oh,
Be
yes.
safe.
And Carolyn, by the way, yes, we will be in Philadelphia in September for that debridement
Woo!
course. So
We are
we
so
are looking
excited
forward
to
to,
be back on the
trust me.
road and having live classes again.
Exactly. I'm looking forward to dusting off my debridement skills and start teaching them again. All right, everybody. Have a great weekend.
All right. Good night. Heal on.